listeners, welcome back to another episode of Hybrid Healing Hour. Today we are going to be discussing marine medicine with our friend and colleague, Dr. Larry Roycraft, who is an ER physician. Please tell our listeners a little more about yourself and how you got to where you are today. I know you've been on our show before, and if they haven't heard, then let's repeat it.
Okay, well, thank you for having me. It's great to be back for both of you. As Dr. Brian knows, I'm was born in Key West, Florida. Grew up in the dive industry. My parents owned a dive shop in Key West for about 45 years, recently retired. So when I got into medicine, I was very interested in diving medicine and hyperbaric medicine, which led me to my training in ER at Charity Hospital in New Orleans, LSU New Orleans, which also had one of the few actual fellowships, accredited fellowships in hyperbaric and diving medicine. So I completed that. And since then, my practice mostly is ER, but I've been very interested in this in more in an academic sense. I give recurrent lectures to FAU Emergency Medicine program about every other year. I'll do the marine and diving medicine lecture. I've lectured and taught at a seminar course for the Uniform Services University of Health Science, the military medical school.
Okay.
With people they have doing austere medicine, or what we in the civilian world would call marine wilderness medicine.
Okay.
And diving and marine medicine is a big part of that. So I've kind of put together in the past little talks on this because it is very common. These injuries and things that can happen in the water are common. And I always say, to the residents here, if you're training in Florida and you don't know how to treat a jellyfish sting, did you really live here? So that's how I kind of gotten into it. It's a little side passion of mine, a very niche field, but very common.
And you actually worked in the dive shop too, right? You worked as a dive master and
that's part of all throughout college and and a little bit in school. I was, as my dad said, his most expensive migrant worker. They would fly me from university on a holiday weekend to work, but I did work a year as a dive master on the boats and in the store during my gap year, and kind of kept up with it since.
So I can't think of anyone more qualified to talk on this subject then.
Yes, I'm interested. I'm from Southern Illinois. Shout out to my Millstat listeners. But I have, came down to Florida, and when I first was doing my ER rotation and a guy came in with a hook through his nose, I was like, oh, Lord, I don't even know how to do this, and like you said, getting stung by jellyfish. And, we're going to talk about a lot of interesting things. And living in Florida, I've learned a lot about basic marine medicine, but we're going to dive into a little bit more, and I'm super excited.
I'm looking forward to it.
So why don't we start with talking about diving, and let's go through the history of diving.
Well, one thing to Deanna, I always say is it's important to understand dive medicine and dive injuries, decompression illness, bends, gas embolism, because no matter where you live, work, or practice in medicine, you will see it. People from Southern Kansas are going to fly to Cozumel for a week and dive.
Exactly.
And they're going to feel a little crappy when they get on the plane. And then that night or next morning, they're going to roll into the local ER. I can't feel my leg.
Exactly.
And so it's, like everything else in the world, travel has made it much closer. But I always like to kick this off on a little bit about the actual, when we think of diving medicine, we just think of the bends. That's kind of the classic. And diving as an activity, it goes back thousands of years. Professional salvage, or people going in to recover things lost, in a shipwreck or in the ocean or in a harbor, goes back documented over 5,000 years. And most of this diving was rooted in commercial or salvage, and then also military eventually. We think about how we do this. Now, first thing you think of, everybody saw, James Bond, you cut the little reed and put it under, and a breathing reed or tube is like a snorkel. Many of your listeners probably have been snorkeling. You only can breathe out of a tube, no matter how big the diameter, for about 3 feet underwater. It's just physics. So, but there are descriptions and even physical evidence, etching, frescoes, etc., that show people using inflated, what is soon to be animal skins or animal bladders, swimming underwater. And that goes back the 9th century BC.
Wow.
That some of these frescoes come from. They kind of progressed from that. And then diving bells first came into kind of with the Renaissance in the 1500s, really used a lot up until the 1800s. And the first really big, kind of leap forward in understanding what's happening is with construction and what they call caissons. So you're going to build bridge, like the Brooklyn Bridge was one of the first ones really done. They put these big metal rings of plates into the thing and they pump the water out. So I can get to the riverbed or ocean bed to work on putting a footing down so I can put a bridge. Well, even though there's no water, you're still surrounded by the ambient pressure, which is the pressure related to the depth. So what they called it is construction. Initially, the first name for this malady was called Caisson's disease, after the caisson. And what they noticed is that as we're getting deeper and deeper, bigger and bigger, more impressive things we're building, workers that came up would get, essentially we recognize now as a decompression injury, but they would get a lot of spinal things. And so they would all end up walking hunched over because of their spinal injury. And there was the bend.
Wow.
I guess it was a vogue at the time for women to have corsets that kind of gave a Grecian bend where they kind of humped over, shut the butt out. But eventually Paul Burt, a physiologist, first described it as a scientific malady in 1878. And so then they started calling it Caisson's disease at that point. And he figured out that if the workers are going, they have to slowly decompress and return back to surface slowly. And that's kind of the same physiology it goes, you know. In the early 1900s, Haldane, the great British physiologist and scientist, actually started experimenting with naval divers at the time, figuring out, okay, we have a way they can breathe, because scuba had been, breathing regulars had been developed at that time, and we can only go so long, so far. And then, we figured that he set out the first tables, how with a diving table, if you're not a certified diver, is a little usually laminated card or a plastic table says if I go so many feet for so many minutes, I come out, and it gives me a group, and then that determines how I have to go from there. What is safe, which I shouldn't get decompression illness, and how long do I have to wait to let that gas offload? And he came up with a group of tables. And the early tables were truly done by usually military or commercial. And it was, I always say, they took Navy and Royal Navy and U.S. Navy divers, and they threw them in a chamber. And we said, well, we went to 100 feet, and we stayed for 100 minutes, and he got bent. That's not good. Let's try 90 minutes. And it was literally trial and error with these poor guys. And then
Glad it wasn't me.
And scuba took its first real jump forward. The first, was scuba. We think of the diving. I say it's really the acronym is self-contained underwater breathing apparatus. So where can a diver go with a tank of gas on their back and something to breathe out of? I'm not connected like you think of the old hard hat they call them the Mark V dive suits with the big brass helmet and the big canvas suit. Well, all of those are connected to the surface by an umbilical.
Right.
Still used in commercial diving today. Not that one, is we're thinking Mark 25 now, but it's still, you have air, gas, and stuff through umbilical. But they started developing it. Really, the big leap forward was in 1934. Jacques Cousteau and his brother-in-law, gone, they really developed the first safe commercial recreational open circuit. You're not rebreathing your own gas. You're not connected to air. You have a tank and you go down. And they called it the Aqualung. Still sold to this day with some minor improvements, obviously, by U.S. Divers Corporation still sells the Aqualung. And that's the most commonly used. Dozens of manufacturers all do different variations. So that exposed a lot more people to problems in the marine environment.
Being able to go further and
to be able to dive
deeper.
And come back home and not be injured.
Right.
Or not die. It's always a good thing, a good end of the day.
Yes. Wow. So I didn't even know that's what scuba, I didn't realize that was an acronym even. So, wow, I just learned a lot there. Right. Thank you.
So what we see, we look at, so we have the bends, but before we get to that, there are other things that can happen from relation to pressure, which an injury from pressure is barotrauma. The easiest thing is your common squeezes. It's gas-filled space in the body that can't react to the pressure. Everybody who's dove under the water in a swimming pool at the beach, feels my ears hurt. Well, that's because your middle ear has to be equalized to the pressure. You see it on planes too. Mm-hmm. Reverse, because you're going from high pressure to low pressure back to high pressure, versus when you're in the water, you're at a relatively low pressure getting to higher pressure. Because as we go under, we're we are exposed to the pressure of the column of water around us. So the areas in our body have to accommodate to that. So the common is the ear squeeze. You learn to Valsalva or equalize your ears. You pinch your nose, you bear down. As you get more experience, you can do it with some jaw movers and thrust. But if you can't, if I have an upper respiratory or I have an allergy issue, I can't equalize, then that you can get a squeeze and bruising or even rupture of the ear. It hurts. You rupture your ear, you have a little fluid, you have a little blood. It's scary, but it's not serious. Also interesting, you can squeeze other things. So sinuses, also if you can, so 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 if you so that's the easy thing. There are some uncommon areas that can have squeeze or injury. The inner ear, because we think about the middle ear, but the inner ear is gastrointestinal, that can have a squeeze. I was joyful enough to have that Brian remembers about 6 years or so. I had a squeeze to my inner ear on a diving when I couldn't. I rose too quickly with some buoyancy issues and I couldn't equalize enough. Still have some tinnitus to this day. Ugh. But it wasn't a decompression injury. It was just squeeze. But they're reported collapsed lungs or pneumothorax. You can build up gas under the tissues, subacute emphysema. You can get gas a number of different areas. Or the worst case is what we'll talk about in a little bit. It's just a gas embolism. Mm-hmm. But the big one everybody knows is the bends, which used to be called decompression sickness. Now the current vogue is decompression injury, I guess, because it's really not a sickness, it's an injury. And it's estimated, the current estimation is about 2.5 cases per 10,000 dives. So, that's a lot of people diving. It does happen. Most cases, thankfully, are mild to moderate, and a lot of them don't need to be hospitalized. They can be treated with, even in the ER with just a period of breathing oxygen. But unfortunately, that means if there's some that are mild, there's some that are bad. Mm-hmm. And interestingly enough, we can see decompression injuries in pilots and astronauts and also our chamber attendants.
Which makes sense.
Actually, I think I've never been able to verify this, but I've been told by several marine dive medicine doctors I've talked with that the Air Force actually has more operational hyperbaric chambers than the Navy because they're pilots. And I know being in Key West and when I was teaching the course with the military school, it was taught out of in Key West has actually the U.S. Army Special Forces Dive Operations School. So every Ranger, every Green Beret, every Army Special Forces and a lot of other countries, they have a permanent school there. And they had told me in their chambers they have treated a lot of flyers because there's also a big Navy air base there. Wow. So it's kind of, you don't think of that. When we talked about different severities, we really break it down very, very technically, type 1 and type 2. So type 1 is typically just a musculoskeletal issue. I have pain in a joint. Sometimes there can be, also you can have some subcutaneous emphysema under the skin. So a decompression hit's been reported in every joint in the body except for the sternoclavicular. So where your collarbone goes to your breastbone, there's a small, I guess it's too small. But usually it's the big joints. It's shoulders, knees, elbows, big joints, hips.
Is the back more common, as you mentioned in the history of?
Unfortunately, the back doesn't have many type 1s because usually back pain is an indication of a type 2, okay. which means it's severe symptoms or neurologic symptoms. Mm. Okay. So sport divers, usually have more type 2. Okay. Because usually it's not so much, and you can have both. You can have shoulder pain from a joint hit and numbness and tingling. It's also difficult because activity diving is a sport. It's an activity, and especially in people who are commercially diving, either as divers or people that spearfish for a living or harvest lobster, or just working a very rough dive. So is my shoulder hurting because we were doing lifting, or I had to pull this anchor up, or did I get a hit?
Right.
And that's hard, and the two overlap. And then the other thing we mentioned before is the arterial gas embolism. And that is when gas comes out of the space it's not supposed to be. So typically it's a rupture of the alveoli in the lung. In scuba, as well as free diving, can occur, and it's basically rapidly ascending while holding your breath. The air in your lungs, because we'll get into pressure, but as you dive down, the pressure increases, so the gas squeezes to a smaller space, and as you come up, that gas will expand. And if you don't exhale, you don't release that pressure, and it will tear through the lungs. And the problem is that it can enter to the arterial circuitry. You're probably thinking of, we also see it what we call iatrogenically with medical procedures or problems. Somebody with a line in an artery and there's air introduced from a mechanical problem during bypass surgery or dialysis, again, and bubbles in the arteries go bad places because arteries go to good places like brains and spines and hearts and lungs.
Right. All your body parts, essentially, and muscles.
Yeah. Fortunately, and to differentiate the two can sometimes be a little difficult. Fortunately, the treatment is the same, hyperbaric oxygen therapy or recompression therapy going in a chamber. There are differences and subtleties of how we treat that. But the whole, as I was kind of getting before, the whole issue is what I like to call bubble trouble. You're breathing a gas. Now, as I said, we use scuba, which is open circuit, meaning your regulator, for those who dive, if I'm not careful, I get water in that second stage where I breathe out of. But you're breathing gas, and it's exposed to the ambient pressure. And pressures, being Americans, we don't like to use like metric stuff like what they use bars or torrs. We call atmospheres.
Okay.
So what that means is the amount of pressure in the atmosphere at sea level. And we know it's because it's not metric, it's a weird number. It's 14.7 psi, which is the equivalent of being at 33 feet in seawater. So that's one atmosphere. But again, if I'm at 33 feet, we call it, I don't want to get scientific. I was a chemist, so I'm a little scientific, but its atmosphere is absolute. And what that means is I'm at 33 feet, I have one atmosphere of water around me, but I have to count the atmosphere in the atmosphere that's above the water.
Okay.
So you're at a higher pressure. So when I breathe that gas in, it's going to act like it's under pressure. So it's going to be compressed. And the one that gives us the most trouble from a decompression, the only one, is nitrogen. Inert gas makes up 78% of the oxygen air that we breathe. And what happens is that nitrogen gets dissolved in the bloodstream under pressure. And so whether it's nitrogen bubbles most commonly, if they come out of solution and enlarge, if they're in the venous system, they cause a decompression illness. If they're in the arterial system, then you get a gas embolism. So they can, and nitrogen's a big player. And as we breathe in, it dissolves in. And how we avoid that is we think we come up slow, or we follow the tables or a computer now dive. And that allows us to come up at we know if we stay less than so many minutes at this maximum depth, I shouldn't have an overt gas load that I can't off-gas. And you off-gas by breathing in.
Mm-hmm. By exhaling.
Exhaling while you're coming up. So if we get too much gas in and we come up, then that gas will come as the pressure goes out of solution and cause bubbles in bloodstream. So the bubbles can do a couple of things. Physically, they can block a blood vessel. If they're in a small, you asked about back pain. Mm-hmm. One of the most common type 2 is lumbar spine injuries. So with lower extremity numbness, weakness, etc. And around the spine is Batson's plexus. It's a venous drainage system around your spinal cord. And the bubbles can physically, in small vessels, they get big enough, they physically get stuck. So it's almost like a stroke. It's something blocking it. However, in the last 20 years, 30 years, with much better science, we know now that there's non-mechanical things. And a lot of these things you're going to recognize after all the talks on inflammation I've heard out of this podcast. Because you got things like endothelial damage with white cell adherence, white cell activation, microvascular leaks, a little bit of hemorrhage, a little bit of, and even things like activating, affecting the complement system. And so all those things we talk about that can happen with systemic inflammation, except now we have a physical thing that's blocking. White cells can even be in the small vessels. Sometimes when they're stuck, they'll be the bubbles will coat the white cells and adhere to it because they think it's like it's a bacteria, it's a foreign thing. And so all that leads to like tissue infarction, which if it's in your spinal cord, it's not good.
Right.
And again, it could also be central nervous, also. So how do we avoid that? Because all this sounds bad.
I was just going to say that. So I mean, based off what I'm hearing is I think, wow, if I have chronic disease, if I have inflammation in my body ahead of time, I don't want to try scuba diving. So please tell me.
No, you can.
Okay.
I mean, there are a subset of conditions that are contraindications. Most of the time, if you go in to sign up for a recreational dive class, you fill a little form. What do you have? What medicines on? What problems you have? And there's a list of things that you may, and you will see it. Because I went to dive shop. Bob says I need to get cleared to go diving. What does that mean? But even when we follow these tables, which were first actually Brian and I trained in it was a little plastic laminated table you clipped on, you kept on you. Now we have dive computers which use some of the same gas laws. They don't. You can follow it to a T and still get hit or injury. There's a large segment of the population that have a pro-patent PFO in their heart, so they can. But the other thing, like I was saying, how do we develop these? Well, now we have gas laws and physics. But in the beginning, I was putting Navy divers of various countries into chambers and see what they did. Well, here's the difference. I'm going diving. I'm a near 60-year-old, slightly out of weight, out of shape doctor that dives once or twice a year. I'm going to Cozumel for a week of diving. I'm using tables and gas laws that are made for 19 to 25-year-old special forces divers who dive 400 to 500 dives a year, get up at 5:30 and run 15 miles before they go to work, So those two physiologies aren't the same.
Right. Yeah.
And then also dehydration is a big factor. And when we think of recreational diving, we always don't drink so much. We think about vacation diving.
If you're in Cozumel, I'm sure you're not drinking water.
Yeah. I've made the argument that Corona is hydrating, but we all know it's not.
Right.
But also the like you said, underlying medical disease, vascular disease, and the workload of the diver. If I'm just sitting there in Cozumel and Brian and I have done wall dives where you're doing a drift dive where the current's so strong you don't try and fight it. You just go down and you go with the flow and you have a little buoy and you come up and the boat's there. Right. But if I'm swimming against that, I'm doing a lot more work.
Right.
And that can lead to troubles. And the computers, they don't necessarily use a table. Most of them use a multi-tissue model where we take typically 6, sometimes up to 10 or 12 body compartments because you think about it physiologically. Bone is going to absorb gas differently than blood, differently than fat, differently than lung, than muscle, than neurotissue. So the computers, and also the dive tables say that your maximum depth. So I go down on this wreck and I go to the bottom and it's at 90 feet. But I spend 3 minutes there and I come up to 60 feet where the deck is. I spend most of my time there. So I'm not unloading gas at 90-foot pressures. Mm-hmm. Table can't figure that out. The computer can because it's constantly monitoring depth, time, and it calculates the absorption of gas into whatever the number of compartments is programmed for. And then as you slowly come up or you go to shallower depths, it'll also be calculating the off gas that you're doing. But again, based on tissues of healthy people. So all these things can lead to, decompression. And then if you're at a deeper depth, and like I said, we come up rapidly, we don't exhale, we get arterial gas embolism. Those tend to be arterial. So the big question is how I got a diver that's hurt and they're on the boat. How do I know what it is? You often don't. The typical rule of thumb is most gas embolisms, you're going to see a problem in the first 5 to 15 minutes. And that's the classic example is a diver surfaces and he's unconscious or she is unconscious. Whereas decompression injuries, maybe not, especially the joint-only pain or a little weakness, may not manifest, and it can be up to 12, 18, 24 hours later before you notice it.
Wow.
What about nitrogen narcosis? Is that similar?
Nitrogen narcosis comes from the absorbed nitrogen, but it's really it's an euphoric effect from the increased pressure of nitrogen in your bloodstream. It's not bubbles. It doesn't really have to do with the size of the bubbles, but that's talked about euphorically, the rapture of the deep. And when you start talking at beyond recreational scuba diver limits, which generally are about 100 to 130 feet, depending on which agency you're following. But when you start getting in the 150, 200 range, you will essentially be intoxicated and a little buzzed, and it happens. But there are people who have died from it, not because of the gas, but because they're just, they'll be there and there'll be a group and you say, this guy just went down the side of the wreck and they're at 200 feet and he takes his regulator out and tries to give it to a fish, because they're intoxicated from the nitrogen. And that just is simple. You just come up to a higher depth and it gets better. That's why with a lot of these things, why we stress, always diving with a buddy, with a buddy pair, someone who can help you, who can say, wow, Brian, put your regulator in. Come on, we're coming up. Grab you physically, pull you up. So when someone has one of these things, whether they're unconscious, whether they have what looks like a stroke, or they have pain or numbness. So what do we do? So in the field, most dive operators, the standard of care now is to carry supplemental oxygen. They have small tanks of 100% oxygen on board. Some people that do a lot of like I said, recreational dive limits. There's people who go way beyond this. There's a subfield called technical diving, where they do very deep. They do rebreathers, where they're rebreathing and mixing and scrubbing their own gases. They're not using air. They're using mixes of nitrogen, oxygen, helium. Now, recreational divers can, with a special certification, get what's called nitrox. The other name for it is enriched air nitrogen, some people call it. Some people call it denitrogenated air. I think it depends on which brand of gizmo you buy to produce it. And what it is basically a different, instead of having, 78% nitrogen and 21% oxygen, you mix more. You pump up your oxygen to 28 to 36%. 32 is the most common. Therefore, there's less nitrogen, so there's less absorption. It allows you not to dive deeper safely, because the oxygen has its own issues at great depth. But it allows you to say, if I'm doing a 80-foot wreck, I may be able to safely get 10, 15, 20 minutes more bottom time or dive time on a gas. That's recreational. But tech divers are diving very deep. Like I said, in the 200-300 range. They may be diving on mixtures of helium and oxygen and nitrogen and have different bottles with different gas mixtures are changing out in the dive during it. That's way off the charts for us.
Okay.
But if you're on a dive boat, or if you're doing a lot of dives, a lot of people will invest and buy, there's some commercially made little oxygen kits for divers. And, so the number one thing is, like anything, we always straighten the ER and see ABCs. Make sure that they're breathing. Make sure they have a pulse. Do I need to rescue breathe? Do I need to open an airway? And you want to apply oxygen at the highest concentration you have available. So the best of these systems have a demand valve, which we would think of in medicine, but basically a scuba regulator, because that makes, and it can provide close to 100% oxygen, at a little bit of pressure. But at the least, some will have a mask, a face mask, even a non-rebreather to do. And that's, what do we do? I mean, there's lots of things. You'll see, they used to say, left side down so the bubbles don't go to the heart. It's really none of that. I mean, basically, it's keep them comfortable. If you're worried about an injury, you may want to worry, their spine's injured. Basically, you want to keep them lying comfortable. Hydration is good, but until you know that what their neuro status is, I wouldn't force fluids on them. But the big thing is put them on oxygen and activate emergency services.
Okay.
Which can be called 911. Now, granted, dive spots aren't always places where it's good to get to 911, so you may have to call the Coast Guard. Brian knows a story about 4 years ago or so. When my parents saw the dive shop, I go down weekends. So my dad goes, look, we're going to go dive this wreck. It's a great wreck, the Vandenberg, one of the biggest artificial reefs in the country. We have this customer that's been diving for a week. He wants to get one more dive. It's going to be great. I told him I'll go. So we'll go. We have a beautiful dive. I'm looking for when come up, and always between dives, especially deeper dives, you do a surface interval. You sit on the boat and you let yourself off gas. Gives me more time on the second dive. And all of a sudden we hear this commotion because there's buoys. They put anchor buoys, like 5 or 6 of them all on the wreck. That's how big the wreck is. Next boat over, dive boat. Somebody goes, have you seen Bill? Have you seen Bill? Where's Bill? Have you seen Bill? And there's commotion because the diver comes up with the dive master unconscious. So they're going and they're like, oh, do you have oxygen? They're yelling. They don't know if they have oxygen. And so we take our big system that's in a dry box, and our dive master swims over. So I go, Dad goes, look at me. I go, okay. So I go and I assess him, and oxygen, he's starting to come around. So we call the Coast Guard. But we're 6 miles offshore. So once he was stable, the Coast Guard said, well, start in. We're sending a fast boat. We'll meet you in the middle. Mm-hmm. So in the meantime, I'm on a cell phone with the Coast Guard, talking to their dispatcher and the medic that's there, giving the report of what I have. And then they come and take him, and they take him to the local Key West ER, which does not have a chamber. But they did the one thing good. They put him on oxygen. By the time he was awake and talking, and the neuro was pretty clean. And put him on IV fluids and called for a helicopter to fly him at sea level. He went to Mercy Hospital down in, which is our local, the South Miami referral chamber for divers. He had some treatments and he did fine and came through fine. But so you have to kind of, when I say activate, think about how we're going to get someone there.
So why don't we move on and talk about some other types of marine injuries?
All right, I know I get really deep in this now. So the only thing I'm going to say just real quick is if you have this with somebody you're diving with, the one thing you want to write down while you know it, what dives you did, how deep, how long your surface intervals were, what kind of gas, and that information should go with him because that'll help the hyperbaric physician who's going to treat him. The other thing for readers to know, if you have an issue, there's a clearinghouse run by Duke University, a hyperbaric medicine clearinghouse called DAN, or Divers Alert Network. They have a number you can call, and you can call them with a question like, if I take amlodipine, can I dive? And they have, hyperbaric doctors, hyperbaric fellows. And they also, but more important, they keep a list, up-to-date registry of every hyperbaric chamber in the country, and also of those, which ones can treat divers. So if I don't know where the nearest is, and you can Google it, it's a 919-684-9111, but I always had Google it at the time. And then that way, they can do it. So anyway, the chamber, we put them in the chamber, and we run them on a table.
It's a hyperbaric oxygen chamber.
Right.
Which is used for many things, right? I mean,
wound care is the big bread and butter. Cyanide poisoning, carbon monoxide, compromised flap and graft. We do.
To be honest, now people are doing it for longevity.
Yep.
There's a lot of off-label. There's about 12 or 13 on-label that the Undersea and Hyperbaric Medical Society recommends. But when I was during my fellowship, our research project, I was working with my director was looking at chronic brain injury, and specifically a lot of kids with CP. It had amazing results, but that's a whole another hour. So anyway, we put you in a chamber. So the two types real quick is a monoplace, what we normally think, the glass tube. Michael Jackson slept in one. Zach Thomas used to have one in the last few years in his house. During the last few years, he would hire a hyperbaric tech come after games and workouts to help him recover.
Yeah.
Probably does work. And then that one, you're breathing oxygen, 100% oxygen, and the person's outside. But most diving injuries, especially if it's a neurologic, we need what we call multiplace. So that's a big, long tube, which can be, the common one is like about 5 feet in diameter. 2 or 3 people can get in.
Oh, wow.
The one we had at LSU was about 30 feet long. You could stand up in it. We could put 16 people sitting in chairs or 4 stretchers. And in the multiplace, you can do critical care. Ventilators, IV fluids, pressors, chest tubes, all that. So, but on those, you're breathing compressed air. Just from a safety and expense to compress that volume is a lot of oxygen, which costs. But then you have a mask or a hood that's delivering oxygen.
Oh, okay.
And you're doing oxygen, gas, and air breaks. And then there's the Navy has the most common, the Royal Navy has. There's a bunch of treatment tables that you do. Most of them run about, minimum's like 4.5 hours initially, and you can do tailing.
We can put the number for Dan in the show notes too.
Right.
Yeah.
So when most people think of what they're scared of in the water, number one is...
I always open the lecture with shark attack.
Yep.
Yeah.
You know, as Brian knows, my dad, he was a longtime dive instructor and diver, he's always said they were more likely to get bit by a pig than a shark. And when his wife went to take dive lessons, we convinced her that they, like the Bahamas, we had swimming pigs, but we don't in the Keys. So it makes a lot of news. It happens. But it's not that common. Now, we tend to see more of it lately, maybe. Again, environments have changed. Seawater temperatures have changed. A lot more people are accessing a lot more water. But overall, worldwide, there's less than 100 bites or attacks a year, usually less than 10 deaths annually. And it really, in the U.S., it's about, averages about 1 to maybe 2 a year as far as fatalities. I read a statistic that you have a 1 in 5 million chance of encountering a shark if you're swimming along the North American coast. So we know the majority, there's about 370 species of sharks. Only 32 have been indicated in attacks or bites. And we think of the big ones, white sharks and tigers and hammerheads and blue sharks and mako shark and the bull shark, which is the most aggressive shark. Mm-hmm. Probably correlates. They also have the highest levels of testosterone of any animal.
Oh.
But can you guess what shark bites people the most, especially here in Florida?
No, I don't know.
You should know, Brian.
Nurse shark.
Nurse sharks. Why? Because they're laying on the bottom. They don't move. They can be small, and people pick them on. No, they go. They grab it. They want to ride it. They grab it.
Oh, Lord.
Or they catch a small nurse shark on their fishing line. They hold it up by the tail, and I guess they didn't pay attention in high school biology to remember that sharks are invertebrate. They don't have a backbone, so they can turn themselves on themselves. Most of those are simple bites, but 70% of shark bites are hit and run. They bite you, they realize you're not a fish, you're not a seal, you're not a dolphin, and they let go. Now, depending on how big and where, a bite can be significant. And because, like you said, stepping on, lower extremity injuries are more common than arms. Legs more than arms, just from swimming and walking. Usually when someone dies of a shark bite, it's not they get eaten, is they die. They either drowned or they bleed to death or some combination.
Or infection.
No, it's really hemorrhage and drowning. Because, imagine if you got a leg, a thigh bite, and they lacerate your femoral artery.
Oh, yeah, that's...
You
don't have time for infection.
Yeah. I hope they get infected.
Right.
So, with a good, last really good dive into the literature, looked at 2,110 documented shark bites or attacks worldwide from 1670 to 2001. Over 40% were U.S. And who leads the way in shark bites in the U.S.? Florida. Followed by California and Hawaii. And because we have large coastlines,
yes.
We have water that people want to get in. Because, for example, there's only been one reported shark bite in Rhode Island or in Washington State or Mississippi, just because nobody wants to swim in the water in Rhode Island. I don't think. It must be beautiful, but again, it's not a
temperature.
It's temperature. It's deeper. It's not beautiful sand beaches. So, again, getting back, people fear sharks. We said that. So keep in mind, I said on average in the U.S., about one person a year dies from a shark bite. On average, about 20 people a year die from dog bites. Somewhere around 30 people a year got to die being struck by lightning. My scary one is 750 people a year die from bicycle accidents. I don't have a pig bite. I got to find that. But, when you get bit by a shark, it's one of two types. It's either territorial or it's feeding. Feeding is a common, you think about it, am I diving later at dusk? Am I in an area where fish are, like their schools, like the mullet are running or the bluefish are running? I'm in a bait ball, Mm-hmm. If you divers know, when you come across a small bait fish or small fish, a lot of times they form into these spherical balls, which can be 10 or 20 feet in diameter, for protection. But it's so cool because you go through them and they all move. And then until you realize, I'm in a bait well, that makes me bait.
Yeah.
So those things, sometimes territorial or protective. If you're out and someone's getting bitten by a shark, really the treatment in the field is simple: is stop the bleeding. Again, see if they got a pulse and breathing. Tourniquet, pressure, packing and pressure. I mean, when you study ATLS and gunshot wound, the first thing before tourniquet is pressure and packing. But tourniquets are one. And then if you have enough time, say you're waiting someplace for an ambulance, then you want to worry about rewarming. Remember, they're cold. Yeah. Even in Florida, in the fall and winter, you can get hyperthermic. So, and they're going to go shocky. So those things. And in the hospital, we would rewarm them and give them IV fluids and antibiotics and prepare wounds and surgery and that stuff. The next thing is fish bite too. So vertebrates, things with the backbone, and the things we speak about like barracuda, eels do bite. Some fish, I always say, some examples of this we have, not native, but if you go into a lot of the canals in Miami and Dade County, you're going to find piranha. Because people thought they were really cool to have a piranha in my tank, man. And then when I get tired of the piranha, what do? I dump it in the canal.
Oh my gosh.
Kind of like, where do you get rid of your pythons in the Everglades? So,
right.
It's rare. They don't really bite. But other species of fish will. Sea lions and seals, we think are cute. They're nasty. They're very territorial and they bite. We don't have them here, but what we do see is you can see anywhere in Florida, they always say, the easy way to tell, we talk about crocodiles and alligators. How do you tell? You stick your finger in the water and you taste it. If it's salty, it's got crocodiles. If it's fresh, it's got alligators. But we see saltwater crocodiles. It used to be very rare, limited to the Thousand Islands in the area of the Southern Everglades Park. But now we see them. We see them in Key West on the beaches. We see them swimming. We see them on docks and boats. And you've all seen the pictures of somebody in Florida, and there's an alligator sitting at the bottom of their pool, Yeah. And they obviously can cause a lot of injury, depending on if a small fish. But usually it's just tissue damage and crush injury, And those are treated, we just take care of the wounds, etc.
Cleaning it well.
Irrigation, debridement. And with fish and eels, we got to worry about just like cat bites. You got to move. Are there broken off teeth? Right. Are there foreign bodies we got to get out? And then appropriate antibiotics. So the one I always bring up next is one nobody thinks about, and that's coral cuts or coral wounds. You think, because the coral is real stealthy. It sits there and it waits for you to come by and it attacks you. No, it's a rock. It's the calcium carbonate skeleton of the coral, and it's there, but we don't pay attention. We're looking at the pretty fish and the water swishing us around, or I'm going for a lobster, and I don't see where my legs are. And most of the corals, there are subspecies of coral that are stinging, and they're called fire coral. This is a big one we know. Fire coral, stinging coral is another one, red stinging coral. They're here. Well, it stings. But even non-stinging corals can be colonized with other organisms, algae and protozoans that do have sting. But the coral tends to give you this like big debridement, almost like a road rash, but the calcium carbonate can break off in the wounds. Sometimes, they get a little, they can be irritated, they can be stinging, so you irrigate them, and like all the stingy things, we just denature the protein, and vinegar is the most common.
What about urine?
Will work if you can get your dye buddy to hold still long enough to pee on them. No, the same thing. All the coral stingings are there. The whole genus or whole family is called selenerates. And that's fire coral, jellyfish, sea lice, sea anemone, Portuguese man o' war. They all have the same nematocyst or stinging cell. The toxin that they envenomate you with is protein-based. So everything we do is trying to denature or deactivate the protein. So that's why we talk about the most common is household vinegar. Mm-hmm. It's acidic. It's not dangerous. It's not toxic to the tissue around you. It's easy to have. It's cheap. But they're taught urine would work. Sometimes the divers used to carry a little bottle of Adolph's meat tenderizer, papain, that you would put on cheap steaks to tenderize them because that would work too. Now, if it's something that, like, say, like a sea anemone where the spine is in you, or a fish where vinegar doesn't want to surface, then we use hot water immersion. Where you just keep the wherever the extremity it is, you put it in like as hot as you can stand, like 100, I think it's like 103-degree water, but just hot as you can make your faucet go, and you have to keep reheating it and leave it there for 30 minutes, 60 minutes. That'll slowly break down the protein and help make the pain go away. The only one we really worry about as far as the most toxic stinging thing we have here is a Portuguese man o' war. You've all seen them on the beach. Those of you listeners aren't in Florida. It's a jellyfish. It has a unique thing is it has a little gas-filled. Its body is not like a moon or not round. It looks like a Ziploc bag. It's a little bluish, gas-filled bag, and it floats on the surface, and it's called the sail, and it just lets the wind blow it. Well, their tentacles can be 10, 15 feet. There's been some found with like 50-foot long tentacles, but it's very painful. I mean, extremely painful. Not like everything in Australia. It won't kill you. There has been, I think, one reported death of someone who went into a anaphylactic reaction. But basically, if you have the thing to remember is the tentacles, even on the beach, can still sting you. They can still fire, like for a week or two exposed to air. And if they're in the surf zone, they can stay viable for a month. And if you have it, the first thing you will see like a little whip linear line where all the if the tentacle's there, you got to remove it. So the best way to do that is just with a cotton cloth, a towel or a t-shirt. You put it on the area, the tentacle will stick to that and come off. You don't want to grab it because worse than your buddy being stung is you getting stung grabbing it. So you could use, tweezers, use forceps in the ER, credit card or plastic card to scrape it. So once you get it off, it's not going to sting anymore. And then you just do, again, denature it. Vinegar, household vinegar. You can use rubbing alcohol, all those things. Some of these are, some bad Portuguese man o' war stings do need like injectable pain medicine. They're so dense.
It could be that bad.
Yeah. And if every mother and father in South Florida in the summer has got a bottle of vinegar stuck in the back of the SUV when you take your kids to the beach because they all got stung. So, but again, those all are pretty much the same. And then we have some other things which are not as usual to think about. Sponges. And we're not talking about, your household sponges originally were sponges from the ocean. But you can see some that are very large in the deep waters. They can be a round column of sponge that's 5 feet across. They can be, and the sponge basically is a little skeleton of like of spicules, usually of like silicon dioxide or calcium carbonate, and surrounded by this soft tissue sponge. Well, if you brush up against it, those little spines, spicules can stick in you. The sponges don't sting, but they usually have algae and hydrozoans and other things growing in them that can. So this one is a very technical medical procedure to get rid of the spines. Take a piece of tape, stick it on, and pull it off. And then, vinegar soaks and the usual stuff. Another common in here is sea lice. We see that a lot here, and they'll be leaving a little flag they fly at the beach. Well, sea lice are not lice. They're not insects. They're actually jellyfish larvae. And some people are much more sensitive. And it almost looks like a little chicken pox, little tiny red lesions. And the clue is they're almost always under clothing, under bathing suit, under wetsuit, under rash guard, because that's where the water gets trapped against your skin and they're on and they sting. The main thing is they're painful, mildly. They're itchy, terribly. So, they're pretty straightforward. Topical
Is that
steroids.
from the water then or the sand?
Well, they're in the water.
Okay.
But normally the wet sand is going to be in that splash.
Washing upon the
and
shore.
And again, it's going to be concentrated in the shallow zone where the kids play. And you'll see it. And you'll see the kid looks like a chicken pox, but it's in the outline of a T-shirt.
Right.
You just know they're there.
Yep. And you just let it work its course, right?
Right. I mean, you could use antihistamines to help with the itching, of course.
The way I look at it is it's very similar to getting bit by no-see-ums.
Exactly.
So you just, like you said, to help the itching.
And that's very common. I touched on before sea urchins. You see they look like little pin cushions. Again, they're just sitting there, but not uncommon to step on them and the spines can break off. Sometimes
But it hurts to step on them.
It hurts from this, that needle in your foot, and it hurts because some of them are colonized with things that sting. That's the one, again, you would have to put someone, I have the number written down. 113 degree Fahrenheit. Don't get a thermometer. As hot as water as you can stand it. But no, you may have to keep it immersed for a half hour, hour and a half. And you have to keep, obviously, refreshing the water stays warm. Occasionally, if the spine is somewhere very bad, the body will degrade and dissolve the spine over weeks. But typically, if it's in a joint or if it's really bad in the foot and right in the plantar fascia and it's right in the weight-bearing area, they can be removed. It's a little more difficult because you kind of have to core it out. You just can't pull it out. They have reverse barbs, but it can be done. The next thing people always talk about ever since the unfortunate death of Steve Irwin is stingrays. Yep. Now, we have very common, the great Atlantic stingray. And, and we've all seen them. And everybody who lives in Florida knows if in the water, shuffle your feet, just so you know that just basically lets you know they're there. And that's it. They don't come attack you. They're sitting on the bottom. You step on them. Their reflex is they have, depending on the species of stingray, between 1 to 3 spines in their tail, and they whip the tail back. So you can get very nice lacerations from that, but they also can envenomate, and they can hurt, hence the name. Some species cause severe pain, like lasting for hours and hours. Some people can have systemic symptoms. They can get muscle cramping and vomiting and vertigo and headaches and paralysis. And unfortunately, with Steve Irwin's, is he got the spine in the heart in the middle of nowhere. Mm-hmm. I was involved in a case a couple decades ago when I was down at Broward General. Someone was driving in a boat on the Intercoastal, and the big stingray came up in the boat, and they're trying to get out, and the actual father got this barb in the heart, too. Now, fortunately, that happened after that, so his adult children were able to get the boat to the nearest marina, called 911, and we knew not to pull it out, and I actually saw the echocardiogram, this little spine in the ventricle, but he ended up going for open chest surgery, open heart surgery. But again, if you pull that out, there's nowhere for the blood to go, but not in your body.
Exactly.
But fortunately, that's rare. Most of the ones we have here are just a pain issue. We have to cleanse. We remove the spine. We x-ray to make sure, or ultrasound now at the bedside to make sure there's no remaining spines or pieces. And you hot water immersion, that kind of stuff. What we're seeing more in the last decade or so are lionfish. So lionfish are a class. Native, endemically, we have stonefish and scorpionfish. When names like that, and they're just, stonefish are ugly. They look like a rock. They're flat. They lay there. You step on them. They have severe, and they cause a lot of issue. The lionfish are just really painful. Severe. It's just pain.
So
intense
is it the
pain.
venom that's painful?
Yes.
Okay, because you said the other one's like a rock and it doesn't.
No, it has spines. It has
has
venom.
spines. Okay.
All
and
these
venom.
things inject venom in you.
Okay.
And they're there, but I'm saying they don't go after and attack you. Like the lionfish are free swimming and they have those beautiful spines along the side. They're not native. Induced here, lots of different theories, but they're endemic. And the problem is that their favorite thing in the world is small, ornamental, pretty reef fish, and they eat them by the ton.
Oh. And
they have no natural enemies here because they're supposed to be in the South Pacific. So there, if you've ever been anywhere here, you've probably seen them. We attempt to remove them. They have lionfish derbies, and there's no season. There's no minimum. You don't even need a fishing license to spear. So there are divers that take a little hand spear and spear when they see them and just leave them there for the fish to eat. They actually taste pretty good. So you see a lot of these in the Keys and in South Florida. We'll have a lionfish derby with the number or the pounds of lionfish, divers can bring in over a weekend or a day. And then you can flay them up once you remove the spines. And they actually very light white fish. So they always have like cooking contests to go along with that.
Oh, fun.
But again, they have a spine, so it's treat the pain, and you have to, again, hot water immersion. But they're very painful. When I first started here, all we saw the lionfish, the 1 or 2 I saw, were people who had them in aquariums.
Okay.
And in handling, but now they're out in the ocean. And when you're talking about step-on and spines, catfish. So catfish, there's 100 species or more, but there are several species of marine catfish which are pretty common. And the saltwater ones are worse than the fresh one. And they have 1 to 3 spines on them depending on the species. And they have a direct toxin, and it hurts. So same thing. Remove the spine, irrigate. Sometimes we immerse, and then we give them, then we'll numb them up after immersion, try and explore, remove the spine, fix it, and then immerse them again. But they're all the same.
Now, one thing that we didn't talk about, it's not a fish, but the barnacles. That's something that was new to, right? Or is that what they're called, barnacles?
Yeah, the barnacles and scallops and bivalves, that's one of the worst things you can do is fall on a seawall.
Right.
And you don't want to grab onto the piling as you slide down. They cause a lot of tissue damage, usually not deep damage, but you've got barnacles, you've got algae, you've got hydrozoans, you've got all kinds of crud growing.
And this is, they grow on surfaces, right? Like you said, the seawall or docks or whatever. And so,
piers, rocks, seawalls, pilings.
Yeah. And
if you have a bunch of them, as you go down, it's essentially a cheese grater.
Yes.
And then, but inside of all that flesh is all kinds of junk.
Right.
And so
gross stuff.
Yeah, you got to go to the hospital. We got to scrub it out. We got to make you not feel it.
Yeah.
And you'll need pretty good, broad spectrum antibiotics for covering what we expect to be in the marine environment, and sometimes they're not so nice things grow in the ocean.
Now, the one thing I'm seeing from this is a lot of those marine injuries that you were discussing don't seem that they medically necessary for antibiotics.
No, most of them, if there's a lot of tissue injury or an open wound, then we would. Mm-hmm. Most of them, it's antibiotics if clinically infected.
Gotcha.
So I have a lot of abrasion from a coral cut. Mm-hmm. Unless I have like a deep open wound that needs stitches, we're going to clean it out the best we can. Mm-hmm. Some of it's also based on patient profile. If you're at risk medically for bad infections, we might. But most of them. But anything that's tissue injury, just like any other injury, whether I fall on the gravel or on the rocks. If I have big wounds, you need to clean. I got to scrub junk out from inside the body. But otherwise, no. Most of them don't need antibiotics. Right. It's
just good cleansing.
Like everything,
and remove the
foreign body that you can. Yeah.
Now, in addition to animals and getting injured by animal or fish or marine life, there's a lot of other conditions associated that people don't realize.
Yeah, there's
and we can be pretty brief on this.
Yeah. I mean, I know I'd love to talk, but there's a lot of different poisonings, toxins, or different things that can come from the marine environment, and most of it revolves around seafood. And as the world grows, seafood now can be transported from across the globe. Mm-hmm. So I can get fish that was in Japan 36 hours ago in the water. I can have fresh cold water lobster flown from New Zealand the next day in a good steakhouse. So we can be exposed to things we weren't. And also, so there are a handful, a lot of them fortunately aren't particularly common, but the most common thing, and we see this here because it is also endemic in South Florida, is ciguatera poisoning. Mm-hmm. And what happens there is that's eating from contaminated reef fish. And the reef fish eat little fish that eat even smaller fish that eat certain algae. And some of the dinoflagellates, small microscopic organism algae, make this toxin. We call it brilliant name, ciguatoxin.
Right.
And this just accelerates up the food chain. It expands. So by the time, and if you look at the fish that this happens in,
right, give
snapper,
examples of that.
Grouper, sea bass, sea perch, flounder, cod, bonito. Those are all
very common.
Now, it also see it in barracuda and parrotfish, which we don't eat much in the States, but in the Caribbean are eaten.
They're eaten more often.
They're eaten often. I've had them both down there. I don't like them. They're not nice. They're not nice tasting fish. But when you're hungry on an island. So the thing is, the contaminated fish smells and tastes normal. The toxin is one that's is heat stable. It's not affected by cooking. And the only way, is here we would know the fish. We've been out in this area off the Marquesas Islands of Key West, and there's been a bunch of ciguatera there. So the fishermen won't go there for a while, until kind of. So it's seen in warm water. So majority of cases, 90% of cases, reported either in Florida or Hawaii. Mm-hmm. followed up then by like Puerto Rico and some of the Caribbean. The symptoms, you get initially you can have some of your nausea, vomiting, diarrhea, but the interesting is it has some neurologic symptoms. So you can feel what the classic symptom, this is a board question for all the ER docs out there, paraoral paresthesia, so numbness and tingling around the mouth on both sides. You can also see some things like temperature reversal. So
like
if I touch an ice cube, it feels hot. If I touch a warm surface, it feels cold. Those are temporary. So it's not usually, it's just miserable. It's not deadly. The treatment, some people still say GI decontamination, pump your stomach. It's not really done much. Basically, it's symptomatic treatment.
There's no test to run for it anyway.
No.
How long does it last?
Usually hours.
Oh, okay.
However, once you get through the acute phase, you do have to avoid seafood for 3 to 6 months.
Okay.
Because you always eat some seafood has some degree of the toxin, just not a high enough level. But once you're sensitized, you can kick off on a fish that wouldn't do before. There's no testing. There are some research tests that CDC does. So the other one that's common is scromboid. And that's from eating contaminated, comes from tuna, dolphin, mackerel, mahi-mahi, all the good stuff. It's a histamine reaction, so it looks like an allergic reaction. Itching, flushing, hives, nausea, vomiting, abdominal pain. This one comes from improper storing of fish. So it was stored at greater than 40 degrees centigrade. So that one we would treat with antihistamines, steroids maybe, breathing treatments, even adrenaline or epinephrine if you're having a bad reaction.
So this doesn't mean the patient's going to be allergic to this for good.
No.
This could be scromboid and not an allergic reaction.
Right, and that's why I was allergic to fish, but I just started eating fish again after 5 years. I really like it. And it's common. It's just the fish wasn't stored properly. The other one, Anasaccharus, I can never say that. Anasaccharus, yeah. Anasaccharioid worm, I think of the roundworm. It's from a larvae of a roundworm. What happens is these larvae are in the marine thing. They're eaten by shrimp, squid, other little crustaceans, and those are eaten by marine mammals like fish that we eat.
Gotcha.
And it's mostly cold water environment, so maybe North Atlantic, Arctic, Antarctic Oceans, coast of Japan, Chile, where fish are eaten, where it's very cold. So we see also in the areas that are cold that like to eat raw fish, sushi, sashimi, ceviche, or improperly, like say pickled or fish that it's not done right. It's non-specific abdominal pain, nausea, vomiting. Sometimes abdominal symptoms have been described as mimicking Crohn's disease. Tough to diagnose. Sometimes unless you cough up a larvae or you see it in the stool. Sometimes the GI doctor will see it on an endoscopy, or they can cause some bowel perforations and obstruction. Surgeon goes in and find there. Usually it's self-limiting. The larvae don't live in humans, so they die off.
Interesting thing about this one is that it can make you allergic to seafood, all seafood, permanently.
Right, because it inflammates. That's why you have those Crohn's-like symptoms, because you're just initiating an inflammatory response.
Does that mean you get like bloody diarrhea?
You could.
You can?
You can. But usually not too long because the larvae are gone. It's just your inflammatory.
Wow.
You can treat it if you see it. You put them on the antiparasitic drugs. Sometimes you actually find a long little worm in there.
Wow.
So that was interesting. So we covered a lot of stuff, and there's still probably plenty more that we can always do another
one.
I can talk for hours on this stuff. Yeah.
But we thank you for coming on today.
Yes.
And
Thank you, Dr. Roycraft.
And you have any of these serious things, most ER docs are good at this just out of habit. So it's okay if you're really in pain from a jellyfish to go to the ER.
And you don't have to be scared to scuba dive.
Go
enjoy your Cozumel vacation.
You do it safely. You do it within the limits. And millions and millions of people do it. And every day and do fine.
Awesome. Thank you.
Thank you. The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.